Hi, my name is Roy Shaw, licensed paramedic and instructor for the ProTrainings training modules. We thought it would be important for us to at least have a couple of videos for each type of CPR provider. We're doing a 2010 AHA update for lay rescuers and how the changes apply to you. And we're also going to do a second video that's specific to the healthcare professional. In this video, we're going to be covering the topics of the 2010 updates, recommendations, and changes for the lay rescuer. So we're going to go through each bullet point, and then I'll try to summarize the explanation for why. Well, first of all, there have been changes to the recommendations for the immediate recognition and activation of the emergency response system based on just the signs of unresponsiveness, as well as initiation of CPR if the victim is unresponsive with no breathing or no normal breathing. Now, let me synthesize that. What's being said here is that instead of having to do the help, can somebody help me, and then the head tilt, and then clink, 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 are you all right, are you okay, look, listen, and feel, basically the recommendations are now, we got to save some time here. And if the person is unresponsive, that's an emergency in and of itself. Call 911. If the person is unresponsive and you're looking at them, you might as well check to see if they look like they're breathing, moving, conscious, or unconscious. If they're not breathing, not moving, unconscious, as the lay rescuer, it's activation of EMS and immediate CPR. Notice here, there's no pulse checks, no look, listen, and feel for breathing. This is all in an effort to simplify the steps for lay people who may not remember how to do an assessment or don't have a lot of opportunity to practice. So this assessment without airway breathing and circulation with immediate activation of EMS is to save time from the moment we recognize an emergency to activation of 911 or emergency response system to the actual first compression. All right. The second point is this. Look, listen, and feel for breathing has been removed from what we call the algorithm, or from the steps of the CPR. The reason look, listen, and feel have been removed is that the American Heart Association has communicated that the International Liaison Committee on Resuscitation, which is a huge consensus of experts, lay people, victims, EMS responders, nurses, and even educators around the world, have taken whatever science they can get their hands on and said, look, is it helping? Is it helping to have them do the look, listen, and feel? Or do we think that it might be complicating things? Well, I may not always agree. I personally believe that you're smart enough to learn how to do a proper look, listen, and feel, and that it's empowering. If you are able to access the training sooner than every 2 years. However, not everybody has that access. So because of that, the American Heart Association recommendations are for those who may only see it once in their lifetime or may only see it once every 2 years without practice. And so they realize that if the person is unresponsive, based on science and some research, if the patient is unresponsive and does not appear to be breathing or not breathing normally, and that not breathing normally is especially attributed to what we call agonal respirations, agonal respirations. That's a really fancy word for just gasping for breath but not taking a breath. That qualifies as no breathing. And if that's happening, the person usually is in full cardiac arrest and compression should be started right away. And in this case, full CPR should be started right away. So by not doing the look, listen, and feel, we're saving those steps. We also think that there's this personal space barrier issue, and that by putting your face next to their face, it's hard to do that with strangers, especially if you're concerned about personal space, infectious diseases, and so on. It removes that altogether, allows you a little bit of a stand back view, and if they're not responsive, not appearing to be breathing normally, you go right into cardiac compressions and CPR. So that's why that change was made. Now, that being said, the third point is that there's been a continued emphasis on high quality CPR with chest compression rates of at least 100 times a minute And the depth isn't 1.5 to 2 inches anymore. It's now a full 2 inches, and we want to minimize the interruptions between compressions and respirations. Now let's talk about that for a minute. It's very exciting, and I'm not going to get too in-depth on it. But there has been some pretty good science done on human bodies as well as animals, pigs and dogs, that shows that in the first 4 to 6 minutes of a cardiac arrest victim, there's residual oxygen in the body. And if the chest compressions could be done deep and fast, at least 2 inches deep, or about a third of the depth of the chest, and at least 100 times a minute, that's more than 1 a second, there is proof through studies that we're building up a pulse pressure, and that it's causing this interthoracic pressure to build, especially when combined with chest compressions and respirations, that helps to circulate the blood at a higher percentage than when we don't do it fast enough or hard enough. What does this mean? It means that if we can oxygenate the brain, the heart, and vascular organs with the more oxygen, in the long run, to simplify everything, I don't want to get too complicated, we're going to be able to have a higher rate of recovery when we make it out of cardiac arrest. Higher rate of recovery means less brain damage, less heart damage, less vascular organ damage. So those deep, fast compressions have at least enough science to let us try this for the next 5 years to see if we improve cardiac arrest outcomes by changing these few steps and re-emphasizing the importance of full recoil, meaning we let the chest come all the way up before we do our next chest compression, but do them hard and fast. Part of this too is why we want to have more people involved, so that we can actually change out compressors about every 2 minutes or when the compressor gets exhausted. So keep that in mind. There has been a change in the recommendation sequence for the lone rescuer to initiate chest compressions before giving rescue breaths. So in other words, forever and ever and ever, we've been doing airway, breathing, circulation, ABCs, ABCs, ABC. It's the first 3 letters in the alphabet. It's easy to remember that way. I'm not so sure that CAB has, and nor do my colleagues believe that there's really any rhyme or reason now to that. So maybe we should have just said do compressions first and then give 2 rescue breaths instead of changing around the alphabet. But regardless of that, the point is that the faster we can do chest compressions, so in other words, the sooner we can get the first 30 deep, fast compressions on the cardiac arrest victim, the better their chance of outcome. Because again, there's oxygen usually in sudden cardiac arrest still residing in the cells of the body. If we can get 30 good chest compressions, building up the pulse pressures, getting the circulation moving, and then give 2 rescue breaths, some science is indicating, and I say some science because it is limited, and the American Heart Association and ILCOR back that. There's limited science here. It's very hard to get good, big studies on this stuff. There's too many variables between out-of-hospital and in-hospital cardiac arrest to actually get hard science that's consistent and big to be able to give you any more data. But so we take what we can get, and there's some science showing that there may be a better outcome from sudden cardiac arrest if we get chest compressions going faster and sooner than stalling by doing the head tilt chin lift thing and trying to get their head back and getting the first couple breaths in. We're still going to do the 30 chest compressions followed by 2 breaths when we do initiate CPR, even as a lay rescuer, trained, certified. But the real emphasis is get the 30 compressions going first instead of getting the airway open and the 2 rescue breaths. Cool thing is, if they're choking, you do 30 chest compressions first anyway. So if they do have an obstruction, it's going to blow that obstruction out 9 times out of 10, and now we've got an open airway when we give the 2 breaths. So in reality, I kind of think it was probably the way we should have been doing it the whole time. But hey, that's why they call it practicing medicine. Practice makes perfect. It's a science. We need to keep evolving in this science, and we do that by practicing, learning from mistakes, learning from successes, and that's why we're doing another update. The compression rate should be at least 100 times per minute rather than approximately 100 times a minute. Small change, what we're saying is faster. People tend to do them less deep and slower rather than going crazy and doing them really fast, really deep. So we're encouraging you to do them at least 2 inches deep or more, and at least 100 times a minute or a little more. All right. The AEDs. Now this is pretty neat. Because of technology, we now have AEDs that when you plug in the pediatric pads, whether it's used for a child between the ages of 1 and 8, or even an infant, which is 1 month to 1 year, if you put the pads in that are appropriate for pediatric, it automatically adjusts the AED to deliver a lower electrical discharge. We call them joules. And in EMS, we do joules per kilogram when it comes to pediatrics, because we can design these AEDs, which have computers on board, to know that and then adjust accordingly for the size of the patient. We can actually now use AEDs much more confidently with lay people when it relates to infant resuscitation. So, the pediatric use of AEDs is now indicated for infants between 1 month and 1 year, but you must use the pediatric pads with the AED. So, I hope this was helpful. I hope that it is going to help you to be a better rescuer as you keep on going. Remember to use the training whenever possible. Have fun with it, and we'll see you next time. Take care.